Загляните, потому что тут как-то...
Что такое?
Вроде я нажала, но она вот скачет, и я не могу понять.
Все.
Okay, good day, my dear future colleagues. Today we talk about amyloidosis and immunodeficiency diseases. Just a moment. Okay. Immunity and immunopathology are proverbial two edges of double-edged sword. It is a defense mechanism, but it can be injurious to the human body in a variety of ways. Broadly speaking, immunity or both defense mechanism is divided in two types: natural or immunity, innate immunity, or non-specific, and specific or adaptive immunity, which are interlinking to each other in their function. Natural or innate immunity is non-specific and is considered as the first line of defense without antigenic specificity. It has two major components: humoral, comprised by complement, and cellular, consists of neutrophils, macrophages, and natural killer cells. Specific or adaptive immunity is specific and is characterized by antigenic specificity. It too has two main components: humoral, consisting of antibodies formed by B cells, and cellular, mediated by T cells. The major function of immune system are as under: recognition of self from non-self, mounting a specific response against non-self, memory of the what was early recognized as non-self, antibody formation, cell-mediating reaction, and memory of what was early recognized as non-self. While normal function of immunity is for body defense, its failure or derangement in any way result in diseases of the immune system, which are broadly classified in the following four groups. One group: immunodeficiency disorders are characterized by deficiency or absent cellular and or humoral immune function. This group is comprised by at least a primary and secondary immunodeficiency diseases, include the dreaded immunodeficiency syndrome. Second, excessive inappropriate hypersensitivity reaction. Hypersensitivity reaction characterized by hyperfunction or inappropriate response of the immune system and cover the various mechanisms of immunologic tissue injury. Autoimmune diseases occur when the immune system fails to recognize self from non-self. A growing number of autoimmune and collagen diseases are included in this group. And the fourth group, possible immune disorder on which the immunologic mechanisms are suspected in their etiopathogenesis. And classical example of this group is amyloidosis. Amyloidosis is the term used for a group of disease characterized by extracellular deposit of fibrillate insoluble proteinase substance called amyloid. Amylin, a Latin word, means starch. For the first time, the term amylon or amylum was introduced in 1838 by German botanist Matthias Schleiden in context of vegetable starch. In 1842, Rokitansky used term amyloid to describe enlarged liver and spleen in patients with chronic diseases and case of so-called larder source diseases. Macroscopically, the property was demonstrated grossly on the cut surface and organ containing amyloid, which stained brown with iodine and turned violet and addition of dilute sulfuric acid. The substance was subsequently named by Virchow as amyloid under the mistaken belief that the material was strange like amyloid. Microscopically, by hematoxylin eosine staining, amyloid appearance as extracellular, homogeneous, and structurally eosinophilic pink hyaline material. It's eosinophilic hyaline material pink. It's stained positive with Congo red staining and show pink red hyaline material and with visualized on polarizing microscope, apple green birefringence is the same emerald. Another special staining used methylcressyl violet. It's a metachromatic staining, pink color. Theoflavine exhibit fluorescence. Alcyon blue stainings blue and due to presence of glycosamine glycans. Periodic acid shifted path reaction, staining pink, and immunohistochemistry to distinguish a chemical component of amyloid. Physical and chemical nature of amyloid reveal the complex its ultrastructural examination. The major component amyloid is a fibril structure, fibril protein, about 95% of amyloid. No fibril component, which included P component, predominantly which is glycoprotein, and there are several other, about 25 types different protein. The major biochemical analysis of fibril protein reveals heterogeneous nature of amyloid. Chemical following two major forms of amyloid fibril protein is human in different clinical pathological setting. Thus, protein can be categorized as under ALE protein, ALE amyloid light chain protein, derived from immunoglobulin light chain, which may be complete light chain or may include amino terminal segment and part of C region of the immunoglobulin light chain, and secreted by monoclonal population of plasma cell. It's a plasma cell detected on plasma cell tumor. AA protein, composite protein, which is derived from larger precursor protein, is the serum called serum amyloid associated protein CCAA, was synthesized from liver. In acute phase, react protein synthesis in liver in response to chronic inflammation, chronic inflammatory and traumatic condition, and thus the level of CAA is high in this condition. It's detected a chronic inflammation. And B amyloid protein derived from proteolysis of amyloid protein, deposited in cerebral amyloid angiopathy and neurofibrillary, is derived from amyloid beta tanglins in Alzheimer's disease. Biochemical minor forms included transthyretin. It is a serum protein synthesized in the liver and normal transported thyroxine and retinol. Mutant form are deposited in family amyloid polyneuropathy. Normal form is deposited in heart of aged patients and senile cardiac amyloidosis. A beta-2 microglobulin, a normal serum protein, component of MHI class 1 and fibril component, and it's small protein which used and which detected in long-term hemodialysis. And minor component, serum amyloid P component. It is synthesized in the liver and is present in all types of amyloid. It's derived from circulated serum amyloid P component. A glycoprotein is proteoglycan and highly sulfating glycosamine glycans. Pathogenesis of amyloidosis. The earliest observation that amyloidosis developed in experimental animals who were injected repeatedly with antigen to raise antisera for human use led to concept that amyloidogenesis was the result of immunologic mechanism. Deposit AA amyloid pathogenesis. The stimulus for production L amyloid is some disorder of immunoglobulin synthesis. For example, myeloma multiple, B-cell lymphoma, and other plasma cell describes it. Excessive immunoglobulin production is in the form of monoclonal homopathy. There is a production of either light chain or kappa light chain or lambda intact immunoglobulin or rarely heavy chain. These take place by monoclonal proliferation plasma cells on B lymphocyte or their precursor. Partial degradation in the form of limited proteolysis of large protein molecule occur in macrophage that are anatomically closely associated with L amyloid, AL amyloid. Non-fibrillar component like AP and GIG play a role in folding and aggregation of fibrinoprotein. Deposit AA amyloid. AA amyloid is directly related to CAA levels, a high-density lipoprotein. CAA is synthesized by the liver in response to cytokine, notably interleukin 1 and 6, released from activate macrophages. The level of CAA are elevating in long-standing tissue destruction, in chronic inflammation, cancer. However, CAA level is isolated do not always lead to AA amyloid. As in AL amyloid, partial degradation in the form of limited proteolysis take place reticular endothelial cells, and AA amyloid, a significant role is played by another glycoprotein, amyloid enhancing factor, is elaborated in chronic inflammation, cancer, and familial Mediterranean fever. Act is nidus and accelerate AA amyloid deposit. Amyloidosis pathogenesis, abnormality folding protein, misfolding of normal protein under some changes microorganism, mutant protein that are prone to misfolding and aggregation, and second is escape of degradation and proteasome macrophage due to mutant of ferment in proteasome, due to structure of protein resistant to degradation, and deposit of abnormal protein in extracellular matrix. Amyloidosis classification. Over the years, amyloidosis has been classified in a number of ways based on precursor biochemical protein type of serum amyloid proteins. The nomenclature or different form of amyloid is done by putting the alphabet A for amyloid, followed by the suffix derived from the name of specific protein constituting amyloid of the type AL, amyloid light chain derived, AA and other. Amyloid protein can be deposited in a localized area and may not be harmful or only affect a single tissue of the body, impairing its function. This form of amyloidosis is called localized amyloidosis. Amyloidosis that affect many tissues throughout the body is referred to as systemic amyloidosis. Also, it may be hereditary and acquired. Classification based on clinical pathological phenomena. Generally, systemic amyloidosis included primary amyloidosis, immunocyte described with amyloidosis, and fibrillar protein AL include, and associated diseases, multiple myeloma and other plasma cell crises. Secondary amyloidosis or reactive systemic amyloidosis, precursor protein CAA, fibrillar protein AA, and associated diseases, chronic inflammation. Hemodialysis associated amyloidosis, precursor protein beta 2, A beta 2M, fibrillar protein, and associated diseases, chronic renal failure. And second group, localized amyloidosis, included senile cerebral, precursor protein APP, and fibrillar protein AB, and associated Alzheimer's diseases, and endocrine amyloidosis, thyroid, calcitonin precursor protein, fibrillar protein ACAL, and associated medullary carcinoma of thyroid, and isolate of Langerhans, amyloid peptide isolate precursor protein, and fibrillar protein IEA-PP, and associated type 2 diabetes, and hereditary amyloidosis consist familial Mediterranean fever, familial amyloidotic neuropathy, and systematic senile amyloidosis. Consist precursor protein CAA and fibrillar AA, and transferrin ATTR and transferrin ATTR. The organ, according to this classification, amyloidosis can be divided to major categories in the subtype: primary systemic amyloidosis, primary amyloidosis consisting AL fibril protein and often severe in the heart, gastrointestinal tract, respiratory tract, peripheral nerves, skin, and tongue macroglia. Treatment AL amyloid is targeted at reducing the underlying clonal expansion of plasma cell. Median survival with no treatment after diagnosis primary amyloidosis about 1 year. Secondary amyloidosis or reactive amyloidosis occurs typically as a complication of chronic infection, tuberculosis, bronchiectasis, and other, and typically disturbed is solid abdominal visceral like the kidney, liver, spleen, lymphoid nodule, adrenals, and thyroid. And familial Mediterranean fever, widespread and over consist kidney, blood vessels, spleen, respiratory tract, and liver. Secondary amyloidosis, most common, or reactive amyloidosis, and typically as complication previously tuberculosis, bronchiectasis, chronic osteomyelitis were the most important condition. Presently is rheumatoid non-infection chronic inflammatory condition associated with tissue destruction, rheumatoid arthritis, ankylosis, spondylosis, inflammatory bowel diseases, and drug abusers, heroin injection due to chronic skin infection, and solid tumors, renal cell carcinoma, Hodgkin lymphoma, and non-immunocyte tumors. Hereditary familial amyloidosis included two groups: familial Mediterranean fever, autosomal recessive, autoinflammatory syndrome, excessive production of IL-1 in response to inflammation, and characterized by attacks of fever with serosal inflammation and widespread amyloidosis, and included AA proteins. And familial amyloidotic neuropathy, autosomal dominant, deposition of amyloid included in peripheral and anatomic nerves, and fibrils are made up of mutant TTRs. Hemodialysis associated amyloidosis consists in chronic renal failure, included beta-2 microglobulin is increased in the serum of this patient. In the past, beta-2 microglobulin could not be filtered by dialysis and the deposit of AB microglobulin. Present era, good dialysis filter decreased incidence of amyloidosis. Mechanism of damage to the tissue consists pressure effect leading to atrophy, accumulation in vessel wall leading to ischemia and also increased permeability, and direct cytotoxicity, amyloidogenic light chain accumulation in cardiac cells, and prefibrillar oligomers are found to be more injurious than actual fibril in Alzheimer's and ATTR amyloidosis. Morphological feature of amyloidosis of organ. Although amyloidosis of different organs show variation in morphological patterns, some features are applicable in general to most of the involved organs. Location of amyloid deposit is general, and amyloid proteins get filtered from blood across the basement membrane of vascular, capillary, and extravascular spaces. Amyloid of kidneys is most common and most serious because of ill effects on renal function. The gross examination, the deposit in the kidneys are found in most cases of secondary amyloidosis and in about 1/3 cases of primary amyloidosis. Amyloidosis of the kidney account for about 20% of this from amyloidosis. Amyloid grossly, the kidney may be normal size or big, enlarged or terminally contracted due to ischemic effect and Merowick vascular lamina. Could surface grossly is pale, waxy, and translucent. Microscopically, amyloid deposition occur primarily in glomeruli, capillary tuft. In the glomeruli, the deposit initially appear on the basement membranes, the glomerular capillary, but later extending to produce luminal narrow and distortion of the glomerular capillary tuft. The result in abnormal increasing in permeability of the glomerular capillaries to macromolecule with consequent proteinuria and nephrotic syndrome. And second, deposit tubules, deposit near basement membrane, later seen in connective tissue between the interstitium. In the tubules, the amyloid deposit likewise begin close to the tubular epithelial basement membrane. And vessel deposit in the wall of arterial leading deposit and arterial vascular involved affected chiefly the wall of small arteriole and venous, producing narrowing of their lamina and consequent ischemic effect. Amyloidosis and clinical feature of renal amyloidosis can present with proteinuria, may be severe enough to result in nephrotic syndrome, increased deposit in glomeruli and interstitium, glomerular ischemia and atrophy of tubules, and chronic renal failure. Amyloidosis of liver. In about half the cases of systemic amyloidosis, liver is involved by amyloidosis. Grossly, the liver is often enlarged, pale, and waxy. Microscopically, the amyloid initially appears in the space of disc and between the cord of hepatocyte, ribbon-like pink staining, compression cord, and shrinking atrophic hepatocyte. Later, as the deposits increasing, they compress the cord of hepatocytes so that eventually the liver cells and shrinking and atrophic and replaced by amyloid. However, hepatic function remains normal even at an advanced stage of the disease. To a less extent, portal tract and Kupffer cells are involved in amyloidosis. Amyloidosis of spleen. Amyloid deposition in the spleen for some unknown reasons may have one of the following two patterns. Saga spleen or nodular. Grossly splenic enlargement is not marked and could often show characteristic translucent pale and waxy nodules resembling saga grains, and hence the name. Microscopically, the amyloid deposits begin in the walls of the arterioles of the white pulp and may subsequently extend out and replace the follicles. And second patterns, large spleen, diffuse. Grossly, there is a generally moderate to marked splenomegaly, weight up to 1 kilogram. Could surface of the spleen show mat-like areas of amyloid, large cells, lard-like. Lard means fat of pigs. Microscopically, the deposits involve the red pulp in the walls of splenic sinus and the small arteria and the connective tissue. Amyloidosis of heart is involved in systemic amyloidosis quite commonly, more so in the primary than in secondary systemic amyloidosis. It may also be involved in localized form of amyloidosis, senile cardiac. In advanced cases, there may be a pressure atrophy of the myocardial fibers and impaired ventricular function, which may produce restrictive cardiomyopathy. Grossly, the heart may be enlarged and deposit amyloid deposit. The external surface is pale, translucent, and waxy. The epicardium, endocardium, and walls show tiny nodular deposit or raised plaques of amyloid. Microscopically, amyloid deposit are seen in and around the coronaries and their small branches. In cases of primary amyloidosis of the heart, the deposit of AL amyloid are seen around the myocardial fibers and wrinkling formation. In localized form of amyloid of the heart, the deposits are seen in the left atrium and in the interarterial septum. Subendocardial deposition can interfere with conduction system leading arterioventricles. Amyloidosis of alimentary tract involved of the gastrointestinal tract by amyloidosis may occur at any level from the oral cavity to the anus. Rectal and gingival biopsy are the common sites for diagnosis of systemic amyloidosis. The deposits are initially located around the small blood vessel, but later may involve a dense layer in the bowel wall. Tongue may be site for tumor-forming amyloid producing macroglossia. Diagnosis of amyloidosis may be detected as an unexpected morphological finding in a case, or the change may be severe so as to produce symptoms and may even cause death. The diagnosis of amyloid diseases can be made from the following investigation: histological examination of biopsy material, kidney biopsy, sural nerve biopsy, rectal biopsy, and gingival skin biopsy have a poor result. And second, fine needle aspiration of abdominal subcutaneous fat. It's the fat cells and Congo red staining, amyloid deposit, positive deposit. And other tests: protein electrophoresis, immunoelectrophoresis of urine and serum, and bone marrow aspiration. Prognosis. The prognosis of patients' amyloidosis. Incidentally, finding of amyloidosis may be an incidental finding at autopsy, or in symptomatic cases diagnosis can be made from the methods given above, biopsy examination being the most important method. The prognosis of patients with generalized amyloidosis is generally poor. Primary amyloidosis, if left untreated, is rapidly progressive and fatal. Therapy in these cases is directed at reducing the clonal marrow plasma cell, as is done for treatment of multiple myeloma. For secondary reactive amyloidosis, control of inflammation or infection is the mainstay of treatment. Secondary amyloidosis has somewhat better outcome due to controllable underlying condition. Renal failure and cardiac arrhythmias are the most common causes of this in most cases of systemic amyloidosis. Okay, dear colleague, take 5 minutes break and we following immunodeficiency disease. 5 minutes break. Okay, continue. Immunodeficiency diseases. Failure or deficiency of immunity system which normally plays a protective role against infection manifests by occurrence of repeated infection in an individual having immunodeficiency diseases. Traditionally, immunodeficiency diseases are classified into two types. Primary immunodeficiency are usually the result of genetic or development abnormality of the immune system. Primary immunodeficiency are usually hereditary and manifest between 6 months and 2 years of life as maternal antibody protection is lost. And secondary immunodeficiency arise from acquired suppression of the immune system as a result of other disease or conditions such as human immunodeficit virus infection, malnutrition, immunosuppression, and immunodeficiency syndrome. Etiology of primary immunodeficiency diseases associated with genetic defects or missing enzymes, specific development impairment, pre-base cell failure, and promoting factor may be infection, malnutrition, and drugs. The classification of immunodeficiency diseases included primary immunodeficiency diseases, 4 groups. 7 combination immunodeficiency diseases, combination deficiency of T cells, B cells, and immunoglobulins. T cells, second group, T cells defect, B cells defect group, and common variable immunodeficit decreases. And secondary immunodeficient diseases consist infection, cancer, lymphoid neoplasm, malnutrition, sarcoidosis, autoimmunity diseases, and transplantation diseases. Classification of primary immunodeficit diseases included primary B-cell immunodeficiency consists X-linking agammaglobulinemia, Bruton's disease, and selective IgA deficiency. Primary T-cell immunodeficiency consists DiGeorge syndrome, ataxia telangiectasia, Wiskott-Aldrich syndrome, complete system deficiency, congenital defect phagocyte consists Chediak-Higachi syndrome, and subcombinate immunodeficiency disease. Because a cure when there is a defect is when any one of the many steps during lymphocyte develop. Subcombination immunodeficit syndrome, defect lymphoid stem cells in bone marrow. Congenital thymus aplasia, defect thymus T cells. T cell signaling deficit consists CD4 plus T cells. X-linking agammaglobulinemia have a bone marrow defect pre-base cells to immature B cells. Common variable immunodeficit diseases have a CD4 T transformating and selective EGR deficit mature B cells to EGA deficiency, and Bayer lymphocyte syndrome have a B cell deficit, and hyper-EG syndrome have a CD4 to B cell mature defect. Symptoms have a primary immunodeficiency and consist of recurrent viral respiratory infections, persistent bacterial infection, sinusitis, otitis and bronchitis, skin and mucous membrane infection, increases susceptibility to opportunistic infections, and recurrent fungal yeast infections, diarrhea and malabsorption, delayed or incomplete recovery from illness, activation of tumorigenesis, especially tumor of lymphoid tissue, and autoimmune diseases, and defect of humoral immunity causes predisposition to the infection caused by bacteria or activation of autoimmune diseases. Defect of cellular immunity causes predisposition to the infection and caused by fungi, viruses, mycobacteria, and tumor growth. Primary B-cell immunodeficiency. Common variable immunodeficiency associated with mature B-cell failure to differentiation into mature plasma secreting cell, antibody forming cell, included X-linking agammaglobulinemia and selective EGA deficiency. X-linking agammaglobulinemia or Bruton's disease, deficiency of B-cell tyrosine kinase causing failure in the development of pre-B cell maturation to B cell. Majority of Bruton disease patients show profound hypogammaglobulinemia involving all immunoglobulin classes with less 1% B cells in normal peripheral blood. Clinical presentation included increasing susceptibility to encapsulated recurrent pyogenic bacteria, pneumonia and Pseudomonas species, skin infection, Streptococcus group A and Staphylococcus aureus, and persistent viral or parasitic infection. Selective EGR deficiency. Patients with EGR deficiency have a EGA level less 5 mg per with normal level of other EGC, and 50% have chronic otitis, sinusitis or pneumonia. EGA committed B lymphocytes fail to mature into EGA secreting plasma cells caused by intrinsic B cell defect. Patients of EGA deficiency are susceptible to allergic conjunctivitis, urticaria and asthma, autoimmune and neurologic disorder, various gastrointestinal diseases and food allergy, and recurrent pulmonary infection. Several combined immunodeficiency diseases include deficiency in both B and T lymphocyte function with markedly low immunoglobulin G, A, and E level. Several combined immunodeficiency diseases associated with children failure to thrive, chronic respiratory infection, gastrointestinal or cutaneous infection, particularly recurrent viral, bacterial, fungal, and protozoan infection in 6 months infants. Primary T-cell immunodeficiency include DiGeorge syndrome, Wiskott-Aldrich syndrome, cartilage hair hypoplasia, ataxia telangiectasia, defective expression of class II MPS molecule, defective expression of CD3 T-cell receptors complex. DiGeorge syndrome or thymus aplasia, named Catch22, have a microdeletion in chromosome 22 and congenital disorder characterized by cardiac abnormality, abnormal phases, thymic absent abnormality or T-cell abnormality, cleft palate, abnormality facies, and congenital heart defect. Patients susceptible to uncontrolled opportunistic infection, impaired in cellular mechanism, profound lymphopenia, T cells less 1020 microliter. Ataxia telangiectasia, autosomal recessive progressive neurodegenerative childhood disorder associated with lack of coordination, cerebral ataxia, and dilatation of facial blood vessel, telangiectasis, and slurred speech. Patients have defective mechanism of DNA repair and are predisposed to leukemias and lymphoma. Extremely sensitive to radiation exposure and susceptible to chronic respiratory infection. Wiskott-Aldrich syndrome, an X-linked recessive disorder associated with thrombocytopenia and eczema, and the multiple phase petechia and hematoma under right ear and eczema of foot. Patients have elevated IgA and IgE and low IgM immunoglobulin. Variable T-cell dysfunction manifested by severe herpes virus and pneumocystic carinii infection, increased lymphoma and autoimmune disease, recurrent pyogenic bacterial infections, usually affected ears, sinuses, and lungs. Congenital defects of phagocytose, named Chediak-Higashi syndrome. Children after during the accelerated phase of the disease. A study by EPAN showed that 35 children who underwent Chediak-Higashi syndrome had a 5-year overall survival of 62%. Have erythrophagocytosis might be suggestive of familial Higashi syndrome, Chediak syndrome, or Gressel syndrome. Acquired secondary immunodeficiency syndrome and we talk about AIDS. AIDS in pandemic, in distribution, and in seen in all continents. 2 million cases of AIDS are being added every year. About 6,000 new cases added per day. What is AIDS? Acquired immunodeficiency syndrome. A syndrome is a group of symptoms associated with the same underlying condition. The variety of opportunistic infections, cancer, cause of variety of symptoms. This group of illnesses with their symptom makes up the syndrome AIDS. What is human immunodeficiency? AIDS is caused by the human immunodeficiency virus. Viruses multiply inside body cell, causes illness. Other viruses which cause illness in humans: common cold, polio, measles, hepatitis, and SARS. Human immunodeficiency virus infection, a global pandemic infection. Among adult 15 and 49 years, complete 1.1%. 40 million infected people of worldwide, 40.1 million deaths, and 40.5 million new cases every year, and 14,000 new infections of day in day. Etiology: the AIDS is caused by an RNA retrovirus called human immunodeficiency virus. There are 4 members of human retrovirus in 2 groups. One group transforming viruses. These are human T-cell leukemia lymphoma virus 1 and 2, and are implicated in leukemia and lymphoma. And second group, cytopathic viruses. This group includes human immunodeficiency virus 1 and HIV 2, causing 2 forms of AIDS. The world, including in USA, common human immunodeficiency virus 1 and human immunodeficiency virus 2, a cases from West Africa and part of India. Both HIV1 and 2 are zoonotic infection, and their origin can be traced to a species of chimpanzees who are natural reservoirs of HIV and most likely source of original infection. Okay, this virus particular in spherical in shape and 140 nanometer in size. In contact, core protein chiefly P24 and P20 and P18. 2 strands of genomic RNA and enzyme reverse transcriptase, and 2 lipid membrane derived from 2-layer membrane, outer membrane of infected host cell during budding process of virus, envelope glycoprotein GP, GP 120 and the GP 41. Beside other genes, 3 important genes code for the respective components of virion. GAG, group antigen, for core proteins, POL, polymerase, for reverse transcriptase, and envelope, for the envelope protein. Thus, genus and viral components act as markers. The laboratory diagnosis of a human immunodeficit virus infection. How does the immunity system? Human immunodeficit virus specifically attacks the CD4 cells. Here, the antibody produced by the immune system are unable to overcome the infection. Over time, HIV progressively weakens the immune system, and the person becomes immunodeficient. A weak immune system can no longer effectively defend the body. Mode of transmission. Most common case transmission of HIV infection occurs by one following 3 routes, and it varies in different populations. Sexual contact in the main mode of spread and constitutes 75% of all cases of HIV transmission. Most cases of AIDS in the industrialized world, such as in the USA, occur on homosexual or bisexual males, while heterosexual promiscuity seems to be the dominant mode of HIV infection in Africa and Asia. Other sexual transmitted diseases may act as cofactors for spread of HIV, in particular gonorrhea and chlamydial infection. Transmission of the via blood and blood products. This mode of is the next larger group, 25%, and a cure and high-risk population. Intravenous drugs abused by sharing needles, syringes comprise a large group in USA. Recipient of HIV-infected blood and blood product who have received multiple transfusion of whole blood or component like platelets and plasma. Perinatal transmission, HIV occur from infected mother to the newborn during pregnancy transplantation, or in immediate postpartum period to contamination with maternal blood, infected amniotic fluid, or breast milk. And occupationally transmission, there have been a small number of healthcare workers, laboratory workers, and those engaged in disposal of waste of sharp who have developed HIV infection by occupationally exposure of HIV infecting material, most often by needle stick injury. It is imperative that these workers follow the CDC guidelines for universal precautions, which include disinfection and sterilization, all reusable device, and use a bleaching solution for distinguish all blood spitting. Sore infection, transmission by other blue fluid. All blue fluid tissue are infection. The virus has been isolated from various body fluids, particularly blood, and pleural, peritoneal, fluid, semen, saliva, breast milk, synovial, vaginal fluid, and body organs pre-transplantation. Urine is a rare cause of spread to staph. There is no definite evidence that HIV transmission can occur by any of these fluids. Isolated cases of site infection reported are in likelihood due to contamination with HIV infection blood. Human immunodeficit virus is cannot be transmitted by casual, not sexual contact, like shaking, touching food, kissing, insect bites, food, air, water, sneezing, spitting, shaking hands, touching, dry kissing or hugging, swimming pool and toilet, and other. Pathogenesis. Just a moment. Included pathogenesis included 8 top tips. HIV is largely relating to the depletion of CD4 plus T cell, helper T cell, resulting in profound immunosuppression. And one step, selective tropins for CD4 molecule receptor GP120 envelope glycoprotein of HIV has selective tropins for cells. The particular has core containing protein P24 and P18, 2 strands of viral RNA, and enzyme reverse transcriptase. Bilayer lipid membrane in study with 2 viral glycoprotein. HIV containing CD4 molecular receptor on the surface. The cell most importantly are CD4 T cell. Other such cells include monocyte macrophage, microglial cell, epithelial cell on cervix, and other. Second stage, internalization GP120 of the virion combination with CD4 receptor, but for fusion of virion with host cell membrane and check-marking co-receptor is necessary. Once HIV has combined with CD4 receptor and CCR, GP41 glycoprotein of envelope is internalized in CD4 membrane. And third stage, uncoating and viral DNA formation. Once the virion has entered the T cell cytoplasm, reverse transcriptase of the viral RNA form and single-stranded DNA. Using single-stranded DNA as template, DNA polymerase, and form it has frequent mutation, making in HIV quite resistant to antiretroviral therapy. Viral integration, the viral DNA so formed may initially remain unintegrated in the affected cell, but later viral integrase protein inserts the viral DNA into nucleus of the host T cell and integrates in the host cell DNA. At this stage, viral particle is termed as HIV provirus. Viral replication HIV provirus having become part of host cell DNA, host cell DNA transcripted for viral RNA with presence at that gene. Latent immune attack of host, latent period, this period is latent period, and immune attack in an inactive infected T cell. The infection may remain in late phase for a long time, accounting for the long incubation period. Immune system does act against and the virus, the participant CD4 plus and CD8 T cell, macrophages, and by formation of antibodies to mount attack against the virus. However, this period is short and the virus soon overpowers the host immune. And CDT destruction, viral particle replicated in the CD4 T cell start forming buds from the cell wall and the host cell. As these particles detach from the infected host cell, they damage part of the cell membrane of the host cell and the causes death of host CD4 T cell by apoptosis. Other proposite mechanisms of CDT cell destruction are necrosis of precursor of CD4 cells by the virus and by formation of syncytial gene cells. Viral dissemination, release of viral particles from infected host cells, spreading of the infection to more CD4 host cells and produced viremia. Routine circulation T virus gained entry to the lymphoid tissue and impact HIV infection and other immune cell infect other cell of the host immune system and also affect no-infected cells. Diagnosis of human immunodeficit viruses may be used test for established human immunodeficit virus, ELISA test, Western blotting test. ELISA test. Initial screening is done by serologic test for antibody by enzyme linking immunosorbent assay against GAG and NV proteins. The term Windows period is used for the initial 2 to 4 weeks period when the patient is infectious, but the screening test is negative while seroconversion in the term used for appearance of antibodies. Besides, ELISA may be false positive in antibodies, liver diseases, recent vaccination against flu and other viral infection. And Western blot of ELISA is positive. Confirmation is done by Western blot for presence of specific antibody against all three HIV antigens, GAG, POL, and NV. Second test, test for defect in immunity, used for diagnosis as well as for monitoring treatment of cases. CD4 T cell counting for CD8 cell counted increasing ratio of CD4 CD8 lymphopenia, hyperhemoglobinemia, increased beta-2 microglobulin level, and platelet count thrombocytopenia. And test for detected of opportunity infection and secondary tumors, fine needle aspiration cytology, exfoliative cytology, and biopsy. Pathological lesion and clinical manifestation in human immunodeficit virus diseases can be explained by four mechanisms. Due to viral infection directly The major targets are immune system, central nervous system, and lymph nodes, persistent generalized lymphadenopathy. Due to opportunistic infection, deteriorating immune system provides the body an opportunity to harbor microorganisms. A list of common opportunities infection against affected HIV, and due to secondary tumors and study of HIV/AIDS is characterized by development of certain secondary malignant tumors, and due to drug treatment, drugs used in the treatment produce toxic effects. This includes antiretroviral treatment, aggressive treatment of opportunistic infection, and tumor. Immunopathological mechanism and HIV infection patient progressive disease include three phases. Early phase lasts about 2 weeks, accompanied by fever, itches, flu-like symptoms with high levels of virus in blood. Middle phase lasting months or several years with anti-HIV antibodies, continuous depletion of CD4 T cells, and the late phase AIDS, characterized by a rapid decline in CD4 T cells, opportunistic infection including viral, herpes simplex, herpes varicella zoster, EBV, Epstein-Barr viral, bacterial, mycotuberculosis, fungi and protozoan, and cancer, lymphoma or Kaposi sarcoma. Normal T helper count is 600 to 1,200 cells in microliter of blood. In AIDS, it is less 200 cells on microliter. The Center for Disease Control and Prevention in 1993 revised the classification system for HIV infection in adult and children based on two parameters: clinical manifestation and CD4 T cell counted. Phase and CD4 T category included A1, A2, A3, B1, B2, B3 middle phase, and final C1, C2, C3 phase. Major neurological illness is central nervous system. Toxoplasma gondii causes encephalitis and is responsible for 50% of CNS mass lesion. Toxoplasma encephalitis, the brain caused with Toxoplasma gondii, progressive multifocal leukoencephalopathy, and demyelinating diseases. Cryptococcal meningitis caused fungi, Cryptococci neophore. Neurological manifestations occur in almost all cases during the course of diseases and are an important cause of mortality and morbidity. Pulmonary infection and lung develop in about 50% of cases and are a major cause of death of HIV. This feature are largely due to opportunistic infection causing pneumonia and tuberculosis. Tuberculosis inadvised human immunodeficit virus infection, often present atypically with extrapulmonary diseases affected bone marrow, bone, urinary and gastrointestinal tract, liver, region, nodes, and central nervous system. It's a pneumonia in AIDS, due pneumocystis uroveci, the foamy exudate filling alveoli containing the causative organism. Gastrointestinal illness. Included inflammation of lining of the esophagus, fungal candida, herpes simplex, cytomegalovirus infection, chronic diarrhea, and also acute and that may be caused by bacteria Salmonella, Shigella, Listeria, and Escherichia coli, and gastrointestinal tumor. And the last staging, many patients, 40% AIDS patients have tumors. AIDS definite malignancy include Kaposi sarcoma presenting as a purplish nodule of skin, mons, gastrointestinal tract and lung, Hodgkin diseases, anal and rectal carcinoma, and high-grade B-cell lymphoma, Burkitt lymphoma. My dear colleague, today, this is my last lecture. I apologize for my English. My lecture are a force major situation. If I read lecture in Russian, they would be more interesting, very interesting. I have not forgot my question that I asked the first lecture. Who said that Claudia Galen is the best physician and also a philosopher? At the Greek famous physician, surgeon, philosopher, considered to be one of the most accomplished of all medical researchers of antiquity, Galen influenced developing various scientists in this discipline, included anatomy, physiology, pathology, pharmacology. He was no younger than 70 when he died, and have a very famous aphorism: leave the table slightly hungry and you will always be healthy. Thank you very much. I wish you a successful session.